We call meeting the order of the Board of Commissioners of Whidbey Health. The board values the public's input and ideas and sets aside this time on the agenda to hear from the public on subjects of concern or support. We will make every attempt for each person wishing to speak to be given an opportunity. All information will be taken under advisement. Generally, no action will be taken during the board meeting, but to ensure board response at a later date, should it be needed, please notify the moderator via the raised hand or chat function. If you wish to speak, then limit your comments to 3 minutes. The board appreciates your comments. Let's do the consent agenda. Do I have a motion?
Motion to approve.
Second.
All those in favor?
Aye.
Aye. Next item is call for points of order. Are there any points of order to come up? Okay, John, public comments.
I just solicited for some, but I have none at this time.
Okay, medical staff report. Dr. Lemion.
I thought Heather said it's going to be here.
Do not see him on unless he's one of the calling phone numbers.
Okay, we will come back to that. We'll do the health tech report next. Don.
Thank you. Just a few items. Patrick and Joy have been spending a lot of time in the hospital over the last few days and last couple of weeks. Obviously, the primary focus right now is continuing to concentrate on revenue collection. Alden, the new interim, seems to be working out pretty well. Seems to be doing a good job from what I can see. I think he just needs to do a little bit more, but I think in those weekly calls, he's starting to get a grip on things, which is great. Our 2024 conference, the speakers, I've just finalized those with Neil. And we're very excited about the speaker lineup as well as the breakout sessions that we're going to be having at the conference. I will be in a position to share the full agenda and the program with everybody probably next week, early next week. And at that time, we will also have the registration link so that everybody can choose the breakout sessions that they'd like to attend. The breakout sessions are going to be strong. And the way we've structured them, it will give everybody an opportunity to attend at least 2/3 of the breakout sessions that we have set up. So I think you'll find that they have a lot of really good value in the breakout sessions. So excited to share that with you very, very soon. If you haven't booked your hotel rooms, I encourage you to please do so. We are already at somewhere in the region of 80% capacity for our conference. I have asked Kelsey, our marketing manager, to look for an approved and preferred overflow hotel in case we do need extra rooms. And then the last two items, the one item is a technology update. I had mentioned in a board meeting, I think 2 months ago, that we were busy doing a beta test on our new financial software and budgeting tool. And that beta test has gone very, very well. And we now have our first hospital has been stood up on the platform, which is Cobra Valley. And both the CEO as well as the CFO at that hospital are very, very happy with the software itself. So we are now ready and in a position to give you a demo. Also, whoever else wants to be on that financial software demo, please let me know. I'll make sure whoever wants to be there will be invited to go through it. Probably about an hour, but I'm very excited to be able to be in a position to give that demo to you at this point. The second piece from a technology point of view that we're working on, I'm working together most of my time with the chairman of our company, Derek, is our EDW, our Enterprise Data Warehouse. What we'll be doing is we'll be setting it up in such a way that we will, on top of the EDW, we will have a business intelligence and analytics platform that will be able to pull out. Everything gets down to extracting the data. But yeah, I think in the next month or so, I'll be able to give you more information on that. But that's something we're incredibly excited about because, you know, for a hospital or for any company to set up something like this on their own, it's very, very costly. It's a huge amount of money from a capital point of view. So we're very excited about that. And then the last thing, quick update is just today, in fact, Faith has a webinar which she would have finished doing. I did pass on that information to Dr. Lenny because he was interested in it, and hopefully he shared it with everybody that he wanted to attend the webinar. But the next 3 webinars, February, March, April, we have a 3-part swing bed series, which is being put on by Carolyn St. Charles. And I really would encourage anybody and everybody who can to attend that swing bed series, because I think you'll get a lot of value out of it. If you can't make any of the webinars after a couple of days, the presentation is up on our website, as well as the video within about 48 hours, somewhere in that region. So if you can't make it in person, you can always go to our site and then go to the presentation. And that's all I have. Thank you.
Okay. Thank you, Don. Next item is quality and compliance report by Shauna. She is not here. Would you like to do that one?
Yeah, I'll pull up channel. Heather's on her way down, she said. Okay. So good. The credentialing stuff, she'll do it.
Right, good.
We can go to the next one. So just a quick overview from Shanna's part is all of our provider scores and quality are above the benchmark national standards. We did have all of our policies throughout the organization updated by the end of the year last year. And our Health and Diversity Committee completed their charter and have been recommendations and still driving that initiative. Next. So we're still working on getting ready for the ISO 9000 certification. Should be surveyed in June. If you look at our infection prevention rates, they're still doing extremely well. No infections at all in certain areas at a 0.34, which was considerably better than even I think 14. 3 events for workplace violence events in December, all were verbal, no staff injuries. Total for 2023 was 54 events, 62% of those were verbal, and those are lower than the previous year. Still working through Meditech Expanse, still have a projected go live in July 2024. Several teams working on that, building up the system and so forth. It's all going pretty well. So we had 20 students successfully supported for their clinical placements, including some physician, nurse practitioner, physician assistant students. We are adding more RN students, other specialties, and the CNA program for 2024. And standardized our education requirements for each specific role throughout the organization and kind of cut that back a little bit to make it less burdensome. 3 initial appointments, 7 reappointments. You can see the list there of the credentialing applications. We'll have those here shortly. See our survey results for our HCAHPS. We're right at or above the national average on everything. You see our total for the ER is 4.63, which is up from last time by, I think it was 0.3. That small stuff, there was about 0.3. So we're still continuing to improve in all those areas. So we received a rating of at least 9 out of 10, 64% of the time, so slightly below the national average for the utilization on the way up. And 46% of the time, definitely would recommend the hospital. So we're still quite a ways behind the national average, but continue to see improvement. See our scores for the different areas. Overall hospital 4.73, max sleep rehab 4.79, primary clinics 4.84, and walk-in clinics 4.59. So those are all right at or above the national average. Okay. Most of those are still on the way up. So, That's the highlights from the report. Any questions? Oh, not, so I have a question.
Good. Okay, Paul, you're up.
Yeah.
Finance report.
I'll get in a second.
So we are reviewing December operating and December year to date. John, if you go down just a little bit to right there. If I can get this marker for attention. Thank you. So we are ending the year. Our fiscal year is calendar. So 12/31 is 12 months ended. For the year, we are finishing with a loss and operating a total net surplus rather, which is a loss, about $796,000. And that compares with a budget for the year of almost $500,000. So I want to talk for just a minute about total operating revenues. This is an area that we've done exceptionally well in this year until December. For the last 3, 4, 5 months, I've been talking about operating results that significantly exceeded budget. And what you're seeing here for December is operating revenues that fell slightly below budget. And there's a reason for that. It has nothing to do with patient volumes. Patient volumes and gross revenues were as good as any month this year. Because that drop and that variance from budget is we are paid different amounts as a percentage of charges for each year. 2021 claims pay at a lower rate than 2020 claims, and 2022 claims pay at even a lower rate than 2021 claims. And the reason for the difference is we've implemented 5% price increases in each of the last few years. And every time you implement a price increase, it does drive your total net revenues up, but your net revenues as a percentage of charges is lower. So in the past, we've used 3 years of paid claims data to calculate what the reserve needed on our outstanding accounts receivable. Up until December, we were using 2021, 2022, and 2023 paid claims data. When you look at our accounts receivable, we have very little accounts receivable that dates back to 2021. So there's no logic in including 2021 in that calculation. So when you exclude 2021 paid claims data from the 3-year pools and make it 2 years, it increases your contractual percentage. And we have, as of December 31, approximately $50 million in outstanding accounts receivable. The contractual percentage went from 63.6 to 67.5, which is almost a 4% increase in our contractual reserves. 4% times $5 million or $50 million is $2 million. So we're missing $2 million that we've had in previous months. And this is a one-time hit. It's a non-cash related expense. It is preventable going forward. This is a one-time event. From this point forward, we will, I shouldn't say never, but we will probably never use 3 years of data in calculating our contractual percent. And that's really the most important thing that I want you to understand with respect to our December month. We are reporting a loss of almost $2.6 million for just a month. Last month, we were sitting here with a $1.8 million positive net surplus. So we are going to be starting 2024 with a clean set of books. We'll be going into audit with a contractual reserve that we can support with data. 2022 and 2023 paid claims data. And our challenge, my challenge, will be to increase our collections as a percentage of charges going forward. And one of the areas that we've identified with great opportunity for improvement is denials. And I'm starting at registration. You get good information when the patient presents. You get that good information in the system, and it won't cure all of your denials, but it'll cure many of them. So this is really low-hanging fruit, and that's really where our opportunity is with respect to reducing denials and increasing our payments as a percentage of charges. So, John, if you'll move on to the next page. This will give you a sense for the great work that our clinicians, folks working in support areas have done throughout the year. Patient days, higher than prior year. Inpatient discharges, higher than prior year, higher than budget. Down here in the ER section, John, if you go down a little bit more. Total ER visits, 19,180 exceeded budget by 584. Outpatient visits, a little bit below budget, but about 4,000 visits higher than 2022. And in the clinic setting, primary care, 48,618 visits on a prior year of 44,819, and pretty much the same for our specialty clinics. Been a very busy year. There's been a lot of good things that have been accomplished here. We've heard from many, many, many patients. And we continue to strive to do our best. And so, do you have any questions? Yeah, go ahead, Greg.
Some of the positive aspects of the financials, are they due to the revenue cycle director, the manager that's this year?
Yes,
okay,
absolutely. We've not had any stable leadership, consistent leadership in those areas, and I think we have it now.
Second thing, I applaud you for coming clean. You know, I think there would be no shortage of accounting type folks that could have bestowed us on the oversight leading to that 1 year thing. So that's good. Third thing I want to say on the record is I'm blown away by the quality that you brought to this organization. It's easy for us to see numbers, not realize that there's keystrokes and discussions and philosophy and a lot of different actions and paperwork behind it. And for you to get this degree of clarity and awareness and conversions with all the data in order to provide it for us as simply as you have, I think is really a tribute to you. So if you're not used to getting attaboys, that was one.
Thank you.
When you talk about 48,000 patients for primary care,
Yeah.
Nathan, what's our capacity, do you think? Is there a number for?
About 46.
Well, I think that's good to know that we're operating at that high capacity in our primary care. And because that's our gateway for our patients to come into. And I think that's also great kudos to the system that we're able to do that. And of course, we're always looking for more primary care access.
We could continue to use even more primary care.
We can use several.
Does that include telehealth primary care as visits, or is that just in person?
I think that's
or
is that just in person?
I think it's in person.
Oh, so we're actually touching more people.
Yes.
With telehealth as well. So that's good.
Yeah. Any other questions?
Thank you, Paul.
Thank you.
Okay, we're gonna jump back up on the agenda to medical staff report and see if we can get a snow report.
There's at least 2 to 3 inches on the ground, and they haven't plowed the highway yet, so I apologize for my delay in getting here. In fact, I tried. I put the order into the snow, so you can have some sort of excuse. We have 2 things to present today: the credentials report, and also a need privilege request form. We have never had a hospice medical director physician designee previously, so the credentials committee has provided that privilege request form for us, and that's been reviewed by the credentials committee and reviewed by the MEC, who has approved it, and we submit that for your approval as well, so that we will get for the position that's designated for the hospice. To fill in, we'll have that specified in there, the qualifications that are required. So present that for your approval. I'm assuming, did that come into your packets?
It's not in fact.
Okay.
I'm familiar with it.
You have before.
So what does the position do?
Okay.
So that the physician designee for hospice is the physician who oversees all the hospice care that the RNs and nurse practitioners are doing. And the designee is the one who takes over when the primary physician is named to be there.
Okay, is there a motion to approve this?
Now, is this also going to be a physician? Yes, as it says, basic education has to be a graduate of an allopathic or osteopathic institution, with an MD or a DO. Okay. Motion to approve.
Second.
All those in favor?
Aye.
Aye. Motion passes.
For credentialing, initial appointments, Robert Hurd, MD, walk-in clinic in Coopville is provisional active. Miranda Montalano, certified nurse midwife, and of course midwifery care, provisional active. Martha Kim, family nurse practitioner, walk-in clinic in Coopville, provisional active.
There a motion?
Motion to approve the initial appointments.
Second.
All those in favor?
Aye.
Aye.
For advancement, Brian Minnow, MD, wound care clinic to active staff. Paul Craig, MD, radiology to active staff, and Lisa Koch, MD, pathology to courtesy staff.
What was their previous role?
Brian Minnow and has been here. He's finished his first year here as provisional, and so he's continuing on as active staff. Paul Craig was a radiologist. He's one of the radiology group, and he's coming in. He's been here a year, been credentialed here for a year, and he's coming on to full active. And the same thing with Lisa Koch as courtesy staff. She was provisional courtesy, and now she'll be fully credentialed.
So would Dr. Minnow, would that be a full-time role?
Well, he's had a full-time role. It's just a matter that for the first year that a physician is credentialed, or any of the providers are credentialed at the hospital, the first year is provisional. They're not able to serve on committees or to participate fully in those, though they can be on a committee. They're not voting members until after they've been here for a full year. And so we've moved them from provisional to active.
And the last question, just for our edification, the wound care clinic, is that full-time? In other words, is there somebody there all the time who has sufficient patients that need wound care?
Yeah, Dr. Ned was working here full-time, and he also has, I believe his nurse practitioner worked with him. And they're both well engaged.
Yeah, good. Okay, thank you.
Okay. Do we have a motion?
Motion to approve the advancements.
Second.
All those in favor? Aye. Aye. The appointments.
And the appointments: Regina Courier, podiatrist, active staff; Peter Young, MD, cardiology, out of the Everett Clinic, courtesy staff; David Carnes, PAC and walking clinic at Goldie, active staff; and Robert Johnson, MD, ophthalmology, is active staff.
Motion to approve.
Okay. All those in favor?
Aye.
Aye.
And that's my report.
Thank you, Dr. Lenny. Okay, let's move back. Jim is not here. Nathan, would you like to give his report?
As far as IT, like I said earlier, still working on medical expanse, everything's going well. Staff's very engaged, although we are seeing a lot of extra hours from them having to spend time building this, but that's part of what we expected. So from a facilities aspect, we did move into the new building for women's health. Very successful. We also got everything moved and opened for the primary care and walk-in out front, the old women's health building. So that all went well as well, and starting to see patients over there, and things are going pretty well. We did receive $500,000 of our funds for the imaging remodel. The Department of Health has approved our CT room, and we started applications on January 8th, went live on the 9th. Moved all our mobile CT on the 15th, and we've had some issues with our new CT since the mobile left, of course. So right now it is down and being worked on. We had to have a new tube delivered today, so hopefully we'll be up by late this afternoon, probably 5 or 6 o'clock. So it's been a challenge, but it happens with new equipment sometimes. So other than that, mentioned wound care. We did remodel the old tub room up there for some additional office space for them because they are busy.
Right.
And we are now, as of the 15th, we're able to lock down the hospital completely so nobody can access any areas from the lobby. Took a lot of work on Tim and facilities part to get all the doors and automatic locks and things installed, but that is working now. And we are still working with Siemens through some issues in getting our new x-ray machine up and running. The table was not delivered. They're not really sure what happened, and so now they're recommending we put in a whole new system at their expense, but we have a lot of questions there.
So Nathan, for the benefit of the public, the lockdown in the lobby does not affect people's ability to present to the main entrance.
The front door still open. They can still access the lobby. It's just keep people from being able to access the administrative areas or patient care areas without somebody letting them in, knowing that it's just a safety issue.
Nathan, I want to comment on the walk-in clinic. There's a lot of excitement in the community about that. I noticed at the Board of Health meeting in the gallery there that people were excited, and on Facebook there's a lot of comments, just the whole row and all positive. Very exciting.
And some of the providers that we just credentialed will be joining that, so we can start to expand hours. I think end of February, something like that. So yeah.
Nathan, on a day like today, snow day, it was pretty obvious that there were lots of areas of the parking lot that were inaccessible. Do we have a snow plan?
We actually, they had a late start because they were trying to do sidewalks, but they're out with their
mini snow plows.
Yeah, mini snow plows clearing the parking lot as best we can.
Okay.
Yeah. So, and actually, we looked at some more equipment for them, for the ones that have to go out and do that. So try to add to that and make it easier.
Okay, good.
All right, for operations and outpatient, we continue to be very fortunate in our recruiting efforts. We had 3 interviews this week. I think we have 4 scheduled for next week for different positions, including primary care. We had a nurse practitioner. He's new, but he interviewed last week that was received very well, so we're going to be making him an offer. We have some that we've already contracted starting, let's see, 2 in February, 1 in March, and then another palliative care provider will be starting in, I believe, September. Behavioral health, I'm sorry, not palliative care. So we're adding to every area, actually, and we've been very fortunate. We have some new providers coming over the next few weeks that are somewhat local, that are interested in coming to work for us. So hopefully we'll be expanding all of our different clinics over time. So we do have a general surgeon that's starting part-time in February, and we hope that she will convert to full-time in the summer when she's out of the military. Same thing with Dr. Myers for orthopedics. Dr. Demler's very happy moving over to Cookeville, so we'll be looking to add someone back to Oak Harbor to kind of backfill that one and add services there. So we're still working with Cardinal to enhance our 340B program. We're trying to get to a point with staff that we can expand our hours at the pharmacy to Saturdays. And we're working on adding specialty pharmacy services to our pharmacies. So I think that's a rehab. Just want to point out that our rehab volumes are up 50% over last year and continuing to grow. We are actually interviewing some more physical therapists in the next few weeks to add to that, and hopefully be able to expand and open up back over in Oklahoma. So,
obviously, we're very interested in the finances. I'd like to make a request, unless any of the board members disagree, that by next month we get a report from January 1st, 2023 through 31 December on the number of new hires, losses, the amount of compensation packages
just for providers,
just no for overall,
and then to see that.
And then what's that?
You're about to see
about to see. So my request has already been met.
Part of it. I'm not sure it's going to meet all of your requests. So Lahala does have a report, which is what I'm going to next.
Okay.
I don't have any updates from nursing other than Department of Health was here last week. We found some areas for improvement, but everything has already been pretty much formalized and put in place. So John, if you pull up Lahala's report. So here is our year-end report for HR. I'm not going to spend a lot of time on the slides. I'm just kind of have John kind of scroll through those. If you want to stop at any point or ask questions, please let me know. But I'll give you the highlights that RM turnover for 2023 was 14.3% compared to the national average of 22.5%. So we're a little over 8% lower than the national average. Total turnover was 18.5% compared to the national average of 25.9%. So we're about 7.5% lower than national average for overall. And we were able to get just over 95% of our performance reviews completed across the whole organization. And I think that the rest of it will be completed by the end of this. So we made significant improvements there. John, if you go, I can't remember which slide it is, go down for me. Keep going. There's our total terminations by department. Go back up. Again, mostly nursing areas, and it's usually personal reasons, moving out of the area, spouse being transferred. Pretty low everywhere else. Go to the next. Terminations within 90 days of hire. Very few. We have that couple that more. Exit survey results. Would you recommend this as a place to work? And 7 yes with reservations, 2 yes without reservation, and 1 no. So pretty good overall.
And that was just for the nursing?
No, that was across the
board.
Okay. Again, there's a list of new hires by quarter. So lower than, I mean, I'm sorry, better than more than hires than previous years. You can see the breakdown. A lot of this is filling positions that have been left vacant. So I think we hired a total of 160 something last year. 49 is what it shows here, but that's not counting replacements.
So the total FTE increase,
Is 41.
that's including the departures. Okay, plus 49.
Well, 49 increase in FTE, the departures would be a one-on-one. So like if we lost somebody and then replaced them, we hired a total of 200 people last year.
Right.
But then replacements would be just a replacement the same FTE. Okay, so we added about 49 new FTEs.
Right.
Breakdown by department. We did something to note. We welcome back 26 former employees who were hired, wanted to come back.
Well,
yeah. Position, mostly RNs registration. We still have high turnover there. We're working on that, as Paul mentioned. 17 new providers last year.
the category leadership, what goes into that group?
This group. So like Marion and Kate would be new hires in leadership. Because they're technically employees. So it also be like you can see here, so Samar, Brandy, Kaylee, Paul, Carl, all the new positions that we filled are either vacant or interim replacement.
Okay.
There's our trending by quarter. Starting to slow down a little bit. This next one, John, I don't know if it has any financial implications on this. Is the part I'm not sure that you're going to see in this.
Right. Yeah, what I was interested in is obviously the total increase in employment compensation costs as a percentage of our overall expenses.
Okay. Okay. We'll get there.
Yeah.
Go on to the next one. Again, just turn over by quarter. By year, so we're significantly lower than for the last 3 years. Significantly lower than the national. The performance evaluations, we got those done. We'll be revamping our evaluation tools this year.
When did they do them?
We had a goal of completing 100% by the end of December. So we can start this year completely fresh. We got about 95%. Okay. And some of those are that we did not give people that are like PRN employees that haven't worked here in a while, probably will become that. Right. So we're trying to clean up that as well. See the human resources team. Some of the newer additions, volunteer coordinator, we just added the HR coordinator, SB days. So you can see some of their accomplishments last year. We went from self-insured to fully insured. We're looking at our retirement plan, not getting good response from the people that oversee that for us. So we're looking at finished all of our union negotiations now, and all the ProTech is now, and WSNA wage scale has been adjusted, and she's still working on the support for service wage scales. Should be finished probably the next few weeks. Investigation, work with compliance. Most of our compliance issues are in those. So you have the slide that you're in. Had our employee survey, we had 74% participation. Ended the year with the lowest turnover rate in the last 3 years, below national average. Just reestablished our volunteer program. We now have about 45 of those volunteers. And I think that's the highlights, unless you have questions.
What's you have an employee engagement survey? Have we seen the results of that?
It was back in August. Okay. I can get them for you if you want to see them.
74% is a pretty good number.
Yeah, we had a good turnout.
Yeah,
and good results. There's obviously areas that still lingering and need to be worked on, but gives us what to focus on.
Right.
Okay. And I don't think I had anything to add on.
That's a big change for HR that you should be able to even put that together.
Yeah, no, it is. They've done a lot of work. They a lot of challenges with their doing.
Right.
Having a good team. I can't think of anything to add on that.
Okay, administrative report.
Yeah, that's what I mean. I don't think I have anything else to throw out here.
Okay, thank you, Nathan.
Yes, sir.
Okay, general board items, do you have any?
Actually, I have two.
Okay,
One is, have we figured out our EMS, you know, we did the resolution, but we have to redo that.
Yeah, I need to check with Brad, see if we got that
We
finished.
have to redo the resolution that we had.
Yeah.
And just remind her of that. Okay, Brad, we're working on it.
Yeah, all right.
The other one is that, went to the health department, you know, I'm on the board of the health department, and Commissioner Rose also as an attendee. I think it's really important that you really get a good establishment between us and the Board of Health. There's a lot of benefits there, but the one thing is that if I can't make it to a meeting, I would like Commissioner Rose to take my place, but we have to kind of appoint her through here, and then they have to approve it.
right.
We can't just, you know, like on some of these committees, if we can't make it, I can just go for you or Greg, you know, whatever, but on the health one, they actually have to kind of make that appointment, so if that's okay, I'd like to ask the board if they would agree to.
No, I have already requested Kate that she be a member of that group, so yes, we need to take a vote on it.
Right.
So you want to make a motion?
I'd like to make a motion that, you know, Commissioner Rose is my backup on the Board of Health. Ron County.
Is there a second? All those in favor signify by saying aye. Aye.
Did you feel the train go by? Did you feel the train go by?
I agree.
Yeah, I think it's a very positive thing. The health department both basically is reaching out, and they want to have a better relationship with the hospital.
Good.
That's great.
And James, the next time you revise the assignments for the committees, if you could just see if you can't do that primary, secondary, which would make sense for that too, you know, because to have two commissioners go to almost every committee meeting is probably not necessary. But we want to make sure that the primary is always there, unless they can't be, then they could let their secondary know, or if they think they both need to be there, then they could, but at least we know we've got the standard throat to choke that's supposed to be there, you know.
Right, now what we're trying to do is we're trying to rotate through the committees so that everybody gets a chance to serve on each committee, so that they get the experience of what's available. So if you have a committee that you're unhappy with, you just come to me, we can see about making some changes.
Yeah.
But we'll try and do this about every 3 or 4 months.
Yeah, like I said, with the Board of Health, it's a little trickier. You can't just, you know, rotate people through it.
And I
The
don't
other
think,
thing I'd like to mention about that is that when I was with the Community Health Advisory Board for many, many years, I was the liaison to the Board of Health. And I'm really familiar with all of the commissioners. I work with all of the county commissioners. So it's a really easy slide in.
Good.
That's great.
just a quick input, James. I hear you, and I appreciate the rotational thing. I would just encourage you to think a little bit longer term, because there's a lot of them. It takes a while to figure it out. So for example, on the compliance committee, compliance ethics, it only meets 4 times a year. So you'd only be at your first meeting possibly, and it's not a small, I mean, it's a big endeavor. So I would just say, you know, somewhere 6 to 9 months.
Well, you could have the primary there all the time.
Absolutely, that's why I think it works.
Have the secondary, that can be a rotating position.
Yeah, and even if the primary rolls off, somebody's going to be the primary, and we haven't lost that aspect of it. And obviously, we've already agreed on the credentials committee that my role is to ensure that we have somebody there when rotating, like Mary Jo is going to be there for the January meeting, and then Kate's going to be there for the February one. So, and that's and the other thing that's important, particularly with the primary, as I spoke to Mary today for the documents control. Some of our committees, you're a non-voting member, ex officio, and it's really, really important that you know that. You know, you don't have a big speaking part and you're not voting, you know, whereas on documents control, it's a very, very active part, maybe one of the most, you know. So anyway.
And then also I had mentioned before that we would like to invite the county to come do a presentation here to the board. You know, the community assessment, the aging and living, and also to invite Dr. Hannemeyer to come up, but she has some, you know, some information on that too, so she's kind of working on that. if we can take a look at the agenda and figure out, give them enough notice, whether it's February or March, invite them to come, it's not gonna be lengthy.
Good.
Okay.
All right, thank you. All right, next item on the agenda, we are required by our policy to have new elections after every election of new commissioners. So at this point, we will have an election for president of the board. So I will open the nominations.
I'd like to nominate James Golder.
Okay, and I'll second that.
Anybody else?
I was gonna nominate James.
Oh, nothing. All those in favor signify by saying aye.
Aye.
Okay, next position, secretary or vice president. Take nominations for that. I would nominate Ron Wall.
I'd second that.
Come to training.
Any other comments? All those in favor signify by saying aye.
Aye.
Okay, thank you. Commissioner comments.
Just an update on the strategic plan. We had intended to start going through the final phases of it yesterday for our first meeting with the Executive Management Council, and got rained out by a DMV visit. So, or DOH, sorry. And so we'll regain that and start next week. I would anticipate it's going to take approximately 5 sessions, or about 2 hours long, and a lot of preparations already in place. So I'll update you as we go and that sort of thing. But the first thing we're going to be starting with is mission, vision, values, and core elements. And we won't go any further than that until we get that done in draft. So if you got any questions, holler at any time.
Okay, I want to say I appreciate the work you're doing on that, Greg, and I am very optimistic that it's going to turn out to be a very good product.
Yeah. Well, I just
thank you very much.
The management council, I just hope they survive.
It's wrong.
Basically my comment is all the years I've been on the board here is that, gone through a number of CEOs, a number of board presidents and things that I just want to reiterate that it's so important that each of us has one vote. And so anything going on within the hospital, all commissioners should know the same thing. So basically it's, if Greg knows something, the rest of us should know something. Same thing all the way through that. You can't keep, to me, it's like super important that keeps the board informed. Nobody's caught off guard or surprised. And it's always hard, especially for new commissioners, to kind of learn what's your lane, what where your involvement is. And so, it's really important that we work with, we have one employee, that's our CEO. And, there again, you can always ask other board members, you can ask him, kind of help define that lane so that we don't, we're not here to manage individual departments. We set what we want him to be doing, but we don't walk into a department and try to, give them directions, and we don't solve problems at the grocery store. And bring it back to either tell them, go back to your manager. That doesn't work, go to our CEO. But there again, it's also going to be brought up at the board meeting that, there's an issue going on out there. We all need to know what's going on.
Mm-hmm.
To that end, it would be really helpful if there is commissioner policy that states these are the committees that commissioners are on. This is their mission. This can be pulled from the hospital, but this is their mission. This is their intent, and this is your role on that committee. So that's in writing, and it's not a word of mouth thing. So that we have that for each committee, even the public health committee, and then we would know that someone has to be appointed when anyone. So all that could be written out, and then that would be in our policy.
Yeah, but MEC, we're at the meeting, but we have no voting rights. So we just give a kind of report back. We're there for information and feedback, but we have no voting. Yeah. On the Board of Health, you are a voting person on the Board of Health, Board of Directions, and so yeah, it'd be kind of nice to have that defined.
And also what the role of the board president is here, and what's the role of the secretary besides you run the meeting. Obviously, you do many other things. What are those defined roles?
So, like for the secretary, whatever, like usually signing, once everybody approves something, it calls for a signature.
We can put all that together.
And then,
something like that would just be great
yeah,
to
if
have.
the president can't be here, then the secretary will go into run the. But other than that, there's no special things. Like I said, we each have one vote. We're all equal.
So Nathan, that's something that we need to do with the new commissioners.
Yeah.
And new commissioner orientation.
Well, that, because you have 3 questions.
So that's a very good suggestion. I would suggest that you get together with Nate and task that to put something together for us.
Easy.
Good job volunteering.
Done.
No, and I don't know if you're all aware that the MEC as a whole went to La Jolla, California and did training with Chartis to get ourselves all up to speed. We plan on bringing, at the grace of Mr. Staggs, bringing Chartis up here to train the board and the new MECB members, so get us all still on the same team and fill in those gaps. So that should be happening sometime in the next few months.
Yeah.
We're working on getting it scheduled.
Yeah.
My comment primarily is of appreciation. I really appreciate all of you that have been available to me. Let me ask questions, especially the ones I've asked more than once. Appreciate that. I'm excited about this opportunity. And I think one of the things that I was commenting to James about this morning was just in the brief opportunities I've had to be on the committee meetings, how much there is to learn and how much I plan to learn. So, you know, I'm really looking forward to this next number of years. Thank you.
Great. Thank you. Marion.
Yeah, hi. So I'm excited to be going to the Washington State Hospital Association Advocacy Days in Olympia, the 29th and 30th of January. So I can go down and hear from the Hospital Association, the big issues that are happening in Washington State, and also be able to take Libby Health's perspective to our state legislators on the bill in Olympia on the 30th. So that's a very exciting thing to do, and looking forward to getting out in the community and maybe doing coffees with the new commissioner, you know, on the south end of the island, and hearing from people what they need to know about Libby Health and getting our message out there on a more regular basis in an informal way.
Mm-hmm. Good. I might mention that there is a bill for the legislature regarding CRNAs. I don't know if you're familiar with that bill, but that is not a helpful bill for this hospital. Do you know who Michelle Abbey is? She's our head CRNA. Abbey, yes. If you would get together with her and talk to her, she knows all about this. She has testified in front of the committee, and she will tell you what problems are on that bill. We appreciate what you're doing very much.
And Nathan's going to also give you perspective to take down there as well.
Good.
But that's good.
Good. So thank you. All right. Anything else?
I'd like to bring up something to just initiate the discussion from the couple that we've had earlier, and that is based on parliamentary procedures. Everybody in this room knows that we've had a couple issues here and there, perhaps not observing the OPMA obligations and regulations properly. I think it would be helpful for us to identify someone who is the board's parliamentarian. That could either be a board member, or if Nathan so chose, it could be somebody like John, but somebody that really, you know, is ready to swat us, you know, before we make a mistake, you know, in how we have an executive session, for example, because there are some very fine points. I'm going to give you an example too, because both of you have done executive sessions, and this is important for you. You both know that in executive session, you must declare the purpose, one of the 4 purposes. You must declare when it's going to start and when it's going to come back, and you're going to not have any votes. But you are also obligated, when you come back, to share how much time you spent. So if you declare that the executive session is going to start at 2:30 and rejoin at 3:15, 45 minutes, you can't start again until 3:15. However, if you finish at 3 o'clock, you've only spent 30 minutes. When you come back at 3:15, you're obligated to say, we only spent 20 minutes. That's an example of the complications of them that don't meet the eye very quickly. So, and there's other things. So I'm not looking for a vote, you know, or anything, but I just want to raise that I think we need to have somebody that has sort of the primary expertise as parliamentarian to help us do the very thing that we know we want to do, the right thing.
So I'll nominate Greg to be our sergeant at arms.
Actually, I want to take that advice seriously, because
No, we used to have an attorney when we had an attorney here.
Yeah.
You know,
We need
and-
another $500 an hour attorney like Nolan did.
I know, but what I'm saying is that was one of the things he did,
Yeah.
but we can't afford that, and you're right, we do need to make sure that we're following that, so.
So with that in mind, I would like to ask Marion if she would be our official parliamentarian.
Oh, my hand.
Which means you would be responsible for keeping us out of trouble.
Sure, I think I will do it I'll do it for 1 year. I think it should be on a rotating basis. So next January, we'll look to, someone else to do it, but I'll do it for 1 year.
But you can't fine us.
Yeah.
It's like in Rotary, you can fine if you do something out, you're not allowed to fine us.
Oh, yeah, the worst example of that is.
Well, that's a good idea to start with somebody that's new, that they're eager, they're learning the rules, and it's fresh in their mind. So I think that's a good thing.
Any other business?
I do have a request.
Yes.
I request that when we use acronyms, that at least the first time around, we say what they are, what they mean. I've recommended this pretty much every group I've ever been in, and today there's 3 or 4 that I've not been with, so.
There's actually a handbook I'll find that has a lot of them listed. So we can
Okay,
okay.
I think for other people that are listening to it,
Yeah.
they're online, that it would be really helpful.
And they are
Yeah, it's breathing.
So they're almost.
Well, in medicine, there are acronyms that have multiple meanings.
Yeah.
And so it's behooves us to make sure that the public is aware of what we're talking about, so.
Yeah.
Appreciate it.
Not to step on the role of the parliamentarian, but do we need to vote and second her, or is she?
No, I don't think so. Yeah, she's accepted the position, and I think that's fine.
Just want to make sure.
That would allow too much wiggle room.
It's in the
It's
fight.
gonna have to- it'll also go in the amendments to the bylaws that there's parliamentary and then they're like yearly and that. So maybe next month we'll do a review of the bylaws. And that would take care of that.
Very good. Anything else? Our next board meeting is going to be Thursday, February 15th at 12 o'clock. If there's no objection, we will stand adjourned.